All right, ready. Hello, welcome. When to see playing about with the screen. Hello, welcome to another episode of the Podiatry Detectives. I'm Sherlock and I'm speaking to Colombo. Say hello, Colombo.
Hi, Sherlock.
Hello, Colombo. Just in case our listeners, because we're making this into a podcast, and viewers are wondering why we are talking about Sherlock and Colombo. Yeah, see that? My green screen umbrella came on screen. Just in case you're wondering, we were wondering at the end of the first episode what we are going to call our show, and we went through various suggestions, and Tosif came up with a suggestion: let's call ourselves detectives, because he's often been called one by his patients. So, hence the Podiatry Detectives. How are you, Tosif?
I'm not very bad at all. I'm pretty good. I've been
not very well. You are very well.
I'm very well, actually. Yeah, I've had my 5K run. I've been for a walk. Along with that, just one outing, not like two different outings.
In case they find you, right? You look really tired. Those bags under your eyes look even worse than normal.
Well, today I just woke up at 5 o'clock in the morning, having to prepare for all these presentations a bit.
You were that nervous? Oh my God. All right. So before we start, today we are going to be talking about first MTBJ, big toe pain. But before we start that, I'm going to put Tosif on the spot again. So at the beginning of each video, I ask him an uncomfortable question, and I'll make him squirm in his chair a little bit. So today's question, Tosif, what is the guilty pleasure that you're looking forward to when this coronavirus pandemic ends? Please make sure it's a PG version answer, please. So what is the guilty pleasure that you're looking forward to?
My guilty pleasure is that I sometimes go to Damascena, which is on Harborne High Street, and I do indulge in their shawarmas, as well as they have like these little, I don't know what they're called, sweet treats. And there's like, pardon? Baklavas. And they have like several selection of them. I like to have like one of each, and they do make me sick afterwards. But yeah, that's my guilty pleasure. What about yours?
You can guess my guilty pleasure, because that's where you find me on like 2 evenings a week. Is to smoke shisha, because that's one of my guilty pleasures. Although I know it's very bad for me, but I do have very mild flavors like watermelon and lemon. But there you go.
It still doesn't mean.
But bear in mind, it is my only guilty pleasure. Is like shisha or hookah. Okay, shall we start the presentation, Mr.
Let's go.
Colombo. Let's go, Colombo.
Okay, let's share the screen first. Okay. Let's go with the page 1. Can you see the presentation?
Yep. Let's go.
Let's play. So today, what we're going to do is that we're going to be talking about big toe, and what are the different conditions which can actually affect big toes. We're going to be delving into the causes, the symptoms, the treatments, and I think you probably will agree that the thing which we are more going to go into a bit more detail is about the treatments and what we would do in the clinic, in the clinical settings for you.
Yeah, this is something that we see a lot of, something that can be poorly managed by certain health professionals, and it's definitely worth. If you've ever had any issues with your big toe, this presentation is something that you definitely want to refer back to a few times. So see if you want to move it on a bit, because I can't see any. There you go. Investigating big toe by the Podiatry Detectives. Okay.
So, some of the common conditions that we're going to be talking about are arthritis. There are different types of arthritis. Osteoarthritis, rheumatoid arthritis, gout, which can actually affect big toes. We're going to be talking about hallux limitus and hallux rigiditus. We'll talk about in a little bit more detail and explain what these technical terms are. Bunions, one of the biggest things or the most common things that I see in my clinical settings. We're going to be talking about that. Turf toe, sesamoiditis, and Abid's going to be sharing some light on
Neuroma. I asked him to put Joplin's neuroma in. Actually, it's a very rare condition, but I have seen it a few times, and it's interesting. So, and it's something that I think fellow health professionals that may watch this presentation might find it interesting as well.
Well, personally, the reason I was thinking not to actually include it is because I'm thinking that this presentation, this video, this podcast is going to be listened by our patients rather than the healthcare professionals. And that's why, and it is a rare condition, hence why I didn't include it. So I kind of focus on
I will talk about it a bit later on, but
yeah,
sometimes misdiagnosed as just bunion pain because it is actually on the site of the where you would normally have a bunion. But okay, we will talk about it a little bit.
Cool. So the first thing which we're going to be talking about is rheumatoid arthritis. Now,
all right. So I'll let Tosi start first.
So rheumatoid arthritis, as we know, is a very common form of inflammatory arthritis which affects the big toe. One of the signs and symptoms, what you'd find is that pain, stiffness, flare-ups, deformities, nodules, these are the, I think pretty much with all the arthritises, these are the common sort of signs and symptoms that you would see. But being a rheumatoid arthritic patient, usually they know that they have got rheumatoid arthritis, and they will come to see us having several issues with regards to the feet, not just the big toe, but big toe is the common sort of affected toe in there.
So let's go back a little bit. With rheumatoid arthritis, in your experience, does it affect males or females, or is it quite equal in its distribution?
It does affect, in fact, actually, it affects female more than male. Okay. The reason I didn't go into too much detail about this, Abid, is because I'm thinking we should actually do a rheumatoid arthritis podcast on its own and how it actually affects it.
But like while we're on this subject, so obviously it affects females more. Now, apart from big toe pain that they get from rheumatoid arthritis, you mentioned they can have pain and stiffness. Now, it's really important to tell people that it's not only stiffness in your feet, you will get stiffness throughout your body, in various multiple joints. So one of the things is, in the early stages, you will be getting random swellings of joints where you're not quite sure why they are swelling up, and you'll think, have I bruised it? Have I done? And then when it moves later on, as Tosi will talk about in a minute, the foot tends to collapse a lot more, and the big toe takes the brunt of that.
Yeah, absolutely. And it's a condition which kind of starts showing its signs in the feet and the hands before it would do anywhere else. So usually we don't really see the severe deformities in this day and age for our newer patients, because the condition is managed really well with the medication.
Really?
However, some of our patients who have been diagnosed for like 30, 40, 50 years, they can come with severe deformities. I think I've added a picture moving forward.
Something that RA, rheumatoid arthritis patients, is not something that I see a lot of. But from managing them in the past, I know it is very difficult, and we've got to be very careful with the kind of orthotics that we put in, because they won't be able to tolerate something that's too aggressive. Would you agree, Tosi?
Yeah, so in terms of one of the things which I would really like to mention in the treatment section is that I always talk to the patients about when they have rheumatoid arthritis, 50, 60 or 70% of their pain is managed by the medication and how good their disease control is, and how is disease behaving. So if they're having a flare-up, that needs to be managed with the medication rather than footwear changes or orthotics. Not going to.
If somebody came to you and they came to you with big toe pain, and they had rheumatoid arthritis, and you decided that one of your interventions was going to be an orthotic, an insole, would you look for certain characteristics in that particular orthotic?
I would. So patients who have severe sort of deformities tend to go toward accommodative orthotics, where we are trying to manage the symptoms, and it's a softer insole. We're providing cushioning. We're doing functional control, but in a minimal sort of level.
Let me just butt in a second, in case anybody's listening and they're thinking, what's accommodative and what's functional? Accommodative essentially it's a more softer material. It's a comfortable material. We're not trying to change how the patient walks too much, unlike a functional one, which is a rigid material, and we're really trying to change the way a patient walks now. Sorry, carry on.
So functional is more towards younger patients who still have doesn't have like a lot of deformities, and they still have really good foot function despite the pain. That's when I'd use a functional device to control the movement of their feet.
Okay, and I mean, obviously, we've spoken about in the first episode about injection therapy. Injection therapy for first MTBJ pain for rheumatoid arthritic patients is a great treatment option. Keeps them going for some time, actually. Would you agree?
Yeah, so generally if the disease is diagnosed really early and managed really well, then the damage to the joints is minimal. However, if somebody hasn't been diagnosed for like a year or 2 years, some of the damage that you end up causing to the big toe or any joint cannot be reversed. So hence why the injection therapies and stuff like that is quite helpful.
Okay. You want to move on, or is there anything else you want to say?
So just to quickly mention, bespoke footwear is another thing that when I worked in the NHS, we closely worked with the orthotist, because a lot of these patients, because they have a lot of deformities, they cannot fit into a normal off-the-shelf sort of shoe.
At the latter stages, you mean? Yeah.
Predominantly at the latter stages or mid to latter stages, because
yeah, you'll see a picture in a minute. I think Thoseef's put one in, because when we say latter stages, people will be thinking, why can't they fit into footwear? And you'll see in a minute why they can't fit into a footwear.
Yeah, as well as if you have an insole introduced for patients like them, and they're cushioning insoles, they have to be fairly thick to be able to go into the shoe. So hence why the footwear is really important when you're considering the orthotics as well.
Absolutely, absolutely. Okay, osteoarthritis.
I've just gone back onto the rheumatoid arthritis.
Now, as you can see from this picture, I mean, look, that's quite an angle for the bunion joint. But you can see almost all the toes are sublux or dislocated, so they're all in a contracted position, aren't they? Mm-hmm. And the arch is completely collapsed.
Absolutely. So this can be quite difficult to accommodate in a normal shoe. So, well, I think osteoarthritis is easily the most common form of arthritis suffered by everybody on the planet.
I see a lot of osteoarthritis in the big toe in like golfers, because I treat quite a few golfers. Now, obviously, because of the swing, because of if they're swinging on their and they're going to pivot on their right foot, oftentimes they'll get discomfort and osteoarthritic changes from there. The other factors, as he's mentioned, as Thoseef's mentioned in the slide, is obviously injury, obesity, overuse, and in my particular demographic, where's it gone? In my particular demographic, when I see a lot of athletes, now athletes can get this at various stages. Thoseef's having a play about with the slideshow.
Sorry, it's not working.
I've seen it in cricketers, I've seen it in footballers, I've seen it in a few footballers actually. Depends on how many times they keep on, how many exposures they have, how many kicks they have, but often it can also happen post-injury. So you've kicked somebody else's foot, you've kicked their stud, you've caused a sprain, or you've caused some micro damage within that joint. It heals, but it doesn't quite heal, and then you get over time it happens again, and you get osteoarthritic changes within there. What kind of demographic, what kind of patients do you see with osteoarthritis in the big toe?
I think generally the ages would be like middle to late 50s, 60s. You start to see the onset of these things. It can be earlier, it can be later as well. It's very much associated with overuse. So if you've got functional abnormalities, or if you are using a particular joint, we're talking about a big toe joint, if you're using it excessively, and if your job involves where you are hyperextending it, if you're moving it all the way up, that overuses it and causes the damage.
Also, let's talk about a little bit about like biomechanics. If you've got very tight hip extensors, calf muscles, hamstrings, you will end up loading more onto the ball of your foot more during a normal walking or running gait. That can lead to an overuse injury over time. It's a contributing factor, and it's often I often try and address that as well as the localized problem. But you are right, it is very much overuse. Tell me about how you treat it in your clinic.
Generally, it often comes with a lot of other things that we're actually seeing, and it doesn't come in as a standalone big toe problem. So you'd see that they might have pasplanus foot type, flat feet. They might have reduced range of movement because of the damage in the joint. So usually the treatments that what we mentioned here is painkillers. They can be quite helpful. Exercises, gentle mobilization exercises, strengthening exercises for the toe is quite a good one. If it's, I talked about hallux limitus moving forward, which is a condition which can be arisen from osteoarthritis. And we mentioned some of the treatments there. Mild to moderate arthritis respond really well to the injection therapies. Severe cases, not so much, because there isn't any joint space left for you to inject anything. Orthotic therapy does a fairly decent job of it, along with the footwear. And like I said, we're going to be talking about hallux limitus and hallux rigidus, and I think that's where we'll go into the treatment a little bit more there.
Okay. Generally, you just went through all the treatments. What I normally do is I will start off with some custom orthotics. They tend to have a first cutout, so they'll have space, and I might give them a varus wedge. So that means I'm tilting the front part of their foot. So and that's built in intrinsically into the orthotics, so they're not putting too much weight on.
Are you talking about the forefoot or the rear foot?
The forefoot. So I'm going to give an intrinsic wedge on the forefoot, and I'm going to tilt the forefoot, as well as I may or may not do anything to the rear foot of the orthotic. I might just give it a supportive arch support. And I normally, that's just my demographic, but they want to get back to doing their activities. So I'm injecting it quite a lot, but I always insist on orthotics and rehab. And in my case, the rehab would be obviously gentle mobilization, gentle movement of the big toe, but I'm looking at their hamstrings and I'm looking at their calf muscles. I'm saying, why are they loading up? It might be something specific. So if I'm seeing a golfer, I don't know anything about golf, absolutely nothing, because I think it's the most boring game in the world. But I do know some physios that see a lot of golfers. So I might send the patient to a particular physio who can have a look at their swing, have a look at the biomechanics of their swing, and see, okay, is there something that we can change? Because they want to carry on doing that particular activity. That's their end point. If you had somebody who's not a sporting person, all they want to do is just walk with the dog, insoles, work pretty well, and a change of footwear, obviously.
We at Movement Therapy Clinic, we're quite blessed that we have osteopaths, we have strength and conditioning coaches, we've got several physiotherapists in-house in the clinic, where we can actually refer to the appropriate person for them to actually have a look at up the chain and help you with your rehab plan.
Okay, cool.
Gout.
Gout.
Oh my God! It is. I read a quote on gout, and somebody said that they've been in a war, they've been shot at, they've been, they had broken bones, they had broken skull, and the pain of gout was worse than the pain of all of them things.
So let me put this into context. Gout is known as an inflammatory arthritis. Now, we have other inflammatory arthritis. You can get similar symptoms in the big toe from ankylosing spondylitis. You can get it from like psoriatic arthritis, which is when you have like a psoriasis and you get arthritic pain. You can also get these rarer forms of inflammatory arthritis. One of them is called SARS, sexually acquired reactive arthritis. There are many different types of reactive arthritis, like inflammatory arthritis. Gout is by far the most common one we see. And if you show me a patient's lifestyle, you show me what they eat, I'll tell you if they're going to get gout or not. You know, gout is one of those things. It does not discriminate. It doesn't matter what you are. If you eat poo, right, you're gonna get gout eventually. It's just a matter of time. Or if you're a heavy drinker, you are gonna get it. And obviously there's other factors. You've put down their high purine diet. We know red meat,
shellfish, all these alcohol, and fish as well in general.
And it's junk food. Is generally they tend to be obese, tend to be overweight. Tell me, also, people that have a lot of sugar, like insulin spikes from sweets and all sorts. I've found that also. Tell me how they present in clinic. This should be interesting. How do they walk in, Tosif?
Usually, you mentioned about all the other inflammatory arthritis affecting the big toe, but I couldn't agree more that gout is by far the most common one which actually affects the big toe, and quite easy one to diagnose, should I say. When somebody comes in, you know that they have gout, and from this simple sort of, if they're not being diagnosed with gout or they're not aware that they had gout before, you can see it's a very angry toe, inflamed, red hot, swollen. In some cases, you can actually see that white toffee discharge coming from the gout as well, and it is incredibly intense.
It's hot, it's really hot. So, okay, so first of all, the patient will be struggling to walk. It is important to ask about trauma, because you never ever know. They might have knocked it, might have been trauma. Now, do you generally send off for bloods before you do anything? Do you normally get?
Again, I'm quite lucky that being in a GP surgery as well, that I can, when I worked in the NHS.
So see, if you're showing up now, man, you're like movement therapy where you've got all these other people. You're at GP surgery where you've got all these other people.
Well, when I worked in the National Health, it used to be easy because they've been diagnosed. I can actually access their notes, their blood tests and everything from wherever they were. It gives you a very good idea, and you can diagnose it easily. But being with the GP in a GP surgery, I can easily send them to the GP, get them diagnosed, and what they need is immediate anti-inflammatories, and I generally get them to start off on whatever they prefer, ibuprofen, naproxen, whatever they use. They go on that to start off with while they're having the blood test. I can never pronounce this. I think I missed the L there. It's colchicine.
I was actually wondering what you wrote down, what you written down, but I thought I'd be quiet.
It's a typo, actually. That's if somebody had a flare up, they generally go onto that medication fairly straight away, and that's for just after the onset. But if they need management as a long term, and they can't control what they eat, and they're not being careful in terms of their drinking and stuff, then they have to go into a low dose allopurinol to be able to manage their gout.
Allopurinol is a tablet. It's a systemic medication. So when they first come to me, and if I've got a good idea, I would do exactly the same as you. So I would ask them to take anti-inflammatories and write a letter to the doctor. I want to see a blood test, because normally, I'll take their bloods as well. Sometimes, because I take bloods all the time, I send them off to a lab in London and I get the results in 2 days. But they have to pay for a private blood test. So sometimes they just go to a NHS doctor. I give them a lecture about lifestyle, a proper lecture, proper finger wagging. Even though we're podiatrists and we're not dietitians, but some of this is common sense, man. You don't need to be a dietitian to know some common sense stuff. And at a later stage, you put steroid injection here. I do a lot. I have injected these, and I'll probably inject 1 or 2 a month, but at least 1 a month. And what I normally do is I put the needle in first. I get an empty syringe, and I'll try and suck up what's in there. You'll see what comes out. It's discharge. It's like lumpy discharge. Take that out, and then leave the needle in there, and then put some like a steroid in there.
It works quite well actually, because as we know that steroid injection, the steroids are anti-inflammatories, and having that localized medication just speeds up that process of
just calms it down. But this gout, unlike the other inflammatory arthritis that I spoke about, this is really lifestyle related. The other inflammatory arthritis is sometimes patients don't have
we don't really know why people would get some of hereditary is one of the main thing, but apart from that, we don't really know why one would develop inflammatory arthritis.
But yeah, and
treatments, I think footwear advice would be great to start off with. Orthotic interventions for acute cases, of course, you're not going to give an orthotic, but if somebody had a recurrent sort of gout onset, gout attack on their big toe, that leaves with the lasting sort of damage to the joint, and in that sort of instance, orthotics can be quite helpful.
So when Tosif's talking about that, what he's talking about is every time you get a gout attack, you get these trophic crystals that form inside the joint, and if you get them once in a blue moon is one thing, but if you get them constantly, you'll get a stiffness of the joint, won't you? So that joint won't be moving anymore. Well, it'll move less, won't it?
Yeah.
That means you'll get a secondary pain now. So now you've got no gout there, but you've got a secondary pain because you've almost got a wear and tear of the joint. Then orthotics would be great then.
I love the way you are further explaining my what I'm actually saying, Sherlock. I'm loving it.
That's why I'm Sherlock. Come on, come on, Columbo. What's next?
Yeah, one of the things that Columbo does really well is that he acts dumb, doesn't he?
He's the most intelligent one out of all of them.
Right, bunions. I think everybody will be wondering about bunions and when you're talking about the big toe. So by far,
before you move on, go back that slide. Go back to that slide there. Now move your cursor over. Explain what a bunion is when you show that picture. So like move your cursor.
I can't even actually see my cursor.
You can't see your cursor?
I can't see my cursor.
Right,
forget about that. I think
so it's a deviation of the toe, isn't it?
Okay, yeah, everybody would know what bunion is. It's just a lumpy, big, lumpy foot, like toe on their feet, It's a deviation of the toe. Can come in several stages. Stage 1, which is early stages, 2, 3, 4. In a fourth stage, the toe would be like underriding and or overriding all the other toes. So yeah, that's what a bunion is.
Okay, cool. So,
right, causes and treatments for the bunion. So exact cause is unknown. Hereditary. It is very much hereditary. I'm going to ask you a question about one of the other things and see what you think of it. Secondary to rheumatoid arthritis. So patients who suffer with rheumatoid arthritis is a secondary to that. Now, we all talk about this, that your shoes are going to make your bunions worse, or patients come to you and say to you that, right, I've got bunions because I've been wearing high heels all my life, or I've been wearing rubbish shoes all my life. Now, what is your take on footwear affecting the bunions?
I'm still of the old school mentality that it is a factor. Just because if I just look at it biomechanically, if you put your foot in that position, if you narrow the toe space over time, and if you wear that particular shoe for 6-7 hours a day, you are going to physically cause, I mean, we know from like Wolff's law, which is if you maintain any structure in a certain position, it will adapt. So if you maintain the foot in a position, it will adapt. So I am still of the thought process that footwear can be a causative factor. I do think, however, biomechanics is something that we don't address more. I think when people say hereditary, I've actually now, I've got to a stage in my life where I'm actually thinking it's not that fact that because their mom had it, they're going to get it. I actually think it's because of biomechanical like structures further up in the chain, that the reason why they're getting it because they're putting more force within that, and that may have something to do with hip rotation. So depending on how your hips, how much internal external rotation you've got in your hips, you will load up more on the inside of your foot. But yeah, you're completely right. What's your thought process on it? Do you think that footwear is a causative factor?
I think it's definitely a contributing factor, especially when it comes to the symptoms and stuff anyway. However, the evidence or the research behind it is very weak. Now that could be for two reasons. Number one, it could be because to be able to do research for a really long period of time, like 20-30 years, to be able to see whether it actually causes effect or not, is really difficult, and time consuming, and financially it's just not worthwhile. And I think that's one of the reasons why we haven't got the research behind it. But yeah, I'd agree to a certain degree that yes, it is a contributing factor. How much, we don't know.
Okay. Treatments. So you put conservative down. Let's go, rather than read these out, what would be if somebody came to you with early to mid stage bunions, they're getting pain around that big toe joint and the first MTP joint, what would be your normal protocol?
So generally, I divide these into two sort of categories. Number one, when patients are getting pain because of compression of the shoe and because of the rubbing of the shoe, if the shoes are tight, what they're getting is that they're getting that superficial pressure on the bony deformity, which is causing that pinching moment and which is causing the pain. Now that has got nothing to do with the joint. And for that, it's very simple. Cushioning pad, footwear, good footwear, nice and wide, or use the material which is a bit more softer upper for the shoe, allows that to breathe. There's gel cushioning pads, there's semi-compressed pad cushioning pad, and that solves the problem. Now, then there is a problem with the joint. If a joint is painful, then I would start to have a look at their function. I would have a look at their gait. I would have a look at their movements from the top all the way to the bottom. And that's after evaluating all that, then whatever I've found, that's when I would give them a functional orthotic to support with that movement. Okay. That's my initial and main conservative management. Of course, if the pain is really bad, I might actually inject in it. Of course, the other things which I do is taping for a short period. But I wanted to ask you, what's your thoughts on splints and taping for the correction of the bunion, as well as, do you do anything different to what I do?
So I break them up into 2 or 3 different categories. There are some ladies who come in, they're not in any pain, but they just don't like it aesthetically. If they don't like it aesthetically, I give them the option. I go, look, you could try a day splint and a night splint, and then if you don't find that is beneficial, I can refer you on to a surgeon. They tend not to even go for the splinting. They just say, refer me on to a surgeon. Fine. Those that don't want surgery, I will do exactly what you said. So footwear, cushioning pads, orthotics, definitely. And I will tell them that we're not going to make this any better, but we'll stop it from getting any worse. Okay.
Yeah, it's more symptom management rather than the correction of the bunion.
But you'll be surprised how many ladies just not in any pain, but they just want surgery. I mean, 2 of our closest friends are going to become surgeons soon, Osama and Aisha. So we'll be sending them to them. It'll be me and you at the bottom level of podiatry, and they'll be there somewhere.
Yeah, well, interestingly, I actually had a conversation with foot surgeon who I asked him the question of that when should I be referring somebody for their bunion surgery, and it was quite interesting to know that he said it all depends on their quality of life. Yeah. And for some people the quality of life is pain, and that's inhibiting their quality of life. But for some people, if they're modeling their feet, their quality of life is that the foot needs to look aesthetically pleasing to be able to for them to do the job. So it varies from person to person, doesn't it?
I think, this is something that I have a particular passion in, because I think that not bunions, but I have a particular passion in the psychosocial impact of foot conditions on a person's psyche. So I don't think podiatrists in general take this seriously. So we are trained to treat pain, all right, generally pain. But when somebody comes to you and says, look, I can't sleep at night because I'm in pain. I hate the shape of my feet. I hate the size I don't like looking at them. And generally we would do exactly what like Atosif's just done and just smile, right? Because we're thinking, she's not in any pain, right? So what is wrong with you? But I take this a lot more seriously now.
I do as well.
Seriously. It's because but I don't think many of our colleagues do. I really don't.
I think I'd agree with you. I think historically, for what I've actually seen when patients have come to see me, and often podiatrists do put them off from surgeries. I inform them about the surgery. I inform them about the procedures, what they will be required to do afterwards, how long the recovery period is going to be, what different type of surgeries that they can actually have. Briefly. And let them make a decision, and it all comes down to the quality of life, and for everybody it's different.
So briefly, we're going to try and boost some surgeons up here. Which are the surgeons that you tend to refer to in Birmingham?
Well, my local surgeon, which is in Edgbaston Priory, is John Malik. If there is anything regarding the forefoot bunions, lesser toe sort of surgeries, I would refer them to John Malik. Mr. Goswami is the one which I did a few months of shadowing around with him, and he's a foot and ankle orthopedic consultant. He's in Sutton Coldfield, and he does midfoot and rear foot surgeries, as well as he works for Walsall Hospital. So that's who I refer to.
Cool.
What about you?
I have 3 surgeons that I refer to. Stuart Metcalf in Birmingham, brilliant surgeon. There is Trevor Pryor, who I send certain patients to, or like Ola Natpadia, who doesn't treat that many patients now, but also brilliant. And then if some patients come and ask for like a minimally invasive surgery because they've seen it on YouTube, and then I send them to our man Kaysar Nazir, because he does minimally invasive surgery. So I'll send him to him. So those 3 are in London, and Stuart Metcalf is in Birmingham. I don't know about you, but I've never had the urge to become a surgeon. I don't know if you've had the urge. It's not something that I did consider it many years ago, but it's not something that you have to have a passion in it. If you don't have a passion in something, you just don't do it.
I think it takes a very long period of time, and yes, you need passion, and that same sort of drive for a long period of time. And I think I'm too old for it. I've got kids now.
Old. What are you chatting about? Look at those young, handsome looks. You're no more than 22 years old. But anyway, I mean, like my passion lies in sports medicine, not in surgery. But I'm not an advocate of surgery, bone surgery.
Neither am I. I think like yourself, I'm much more involved in sports, and that's where moving forward, that's where my focus is toward. And that's why I enjoy doing so.
Okay.
So, yeah.
Do you want to move on? What have we got left?
So, okay, hallux limitus and rigidus. So hallux limitus and rigidus is mere, a term which tells you that limited movement in big toe and no movement in big toe at all. So it can be risen from all the things that we've mentioned previously: arthritis, osteoarthritis, functional movement, structural abnormalities, the feet that we've actually inherited. All these things can have an impact and cause functional, the hallux limitus or rigidus. There is a slight distinction between functional hallux limitus and then hallux limitus. And functional hallux limitus would be when you are weight bearing and you just cannot get that windlass mechanism going, and due to the positioning of your foot, the movement in the big toe is reduced. But as soon as you lift your foot up and then you try to move it, there is full movement available in the big toe. One of the symptoms, again, same to all the other things: pain, stiffness, inflammation, loss of function, and it's very similar to osteoarthritis sort of symptoms. In terms of the treatment-wise, I think it's you take a patient as a whole and try to identify, be a detective, be a Columbo, and identify where this is coming from, whether it is a localized issue, whether it's coming all the way from up the chain, and that's how you can treat it successfully. But there's some examples in terms of footwear. If you do have hallux rigidus or hallux limitus, you would, if you use a rocker bottom shoe, that generally helps you to move off. Big toe movement is required to be able to toe off. So them sort of shoes, stiff shoes, they help you to do that. Orthotics, I use orthotics very often. As you mentioned with the first ray cutout, it's very much, again, dependent on where it's coming from, and then treating it that way. Injection therapy, again, the same thing as we mentioned before. If there is localized pain, it's inflamed, it's causing trouble, and it's limitus. Limitus meaning that it still has some space in the joint for you to kind of inject in. When it becomes rigidus, then there isn't any space in there, and it's really difficult to get in there and inject. And my experience hasn't been great. Not that I've injected a lot of rigiduses, but usually I've seen people who been to somebody, had an injection, and that flared up the symptoms even more. Surgery is the one which I want to talk to you about. Is that in rigidus, a lot of the time that you actually get that dorsal lipping, and that's bony development on the top. Now, when would you consider sending them for a surgery? And we know that it's a progressive condition. It's a progressive condition. Limitus turns into rigidus, and then rigidus goes into more fixed and fixed.
When footwear and orthotics haven't had an effect on their lifestyle, and they still are not able to do the activities that they want to do, then I would consider referring on to surgery. I would agree with everything that you said about both conditions. I find when I see this, you'll often see this, and Tosif may agree with me, may or may not agree with me. Sometimes when a patient presents with heel pain or arch pain, they often have hallux limitus. They have more because they're having to load other structures up. So when your toe hasn't got enough movement up, something else is going to compensate, and that could be various structures. One of the things also is if you've got limited motion in your cuboid joint, which is on the outside of your foot, you could whip into your into your big toe a bit quicker than what you would normally do. That could lead to wear and tear and lead to hallux limitus. Generally I would treat it exactly what you said, and surgery for me, because normally by the time they require surgery, you're talking about fusing it, aren't you? It's like essentially you're talking about fusing the big toe, because they're not going to do anything. Depends on how much damage has already been done to it.
So basically, the reason I said that is that I've had some recent sort of experience with regards to the dorsal lipping. So if you have an X-ray done, and the X-ray shows that there is a decent sort of joint spacing in the joint, or the quality of the joint is rather good, but they have a little dorsal lipping on the top. So if you've got a joint which is getting blocked from the top,
yeah,
then what happens is that by just literally shaving off the bony prominence from the top, just improves the toe pain considerably, and it's a fairly decent and quick recovery as well, with the very good success rate.
Okay, I have no knowledge of it, but
yeah, but this is sort of moderate limitus sort of presentation. But when it gets to rigidus, there is two things that usually it goes into that rigidus fused form anyway, because it's progressing into that. So you might not require a surgery. All you do, if I usually try to remove the movement. So my orthotic would have like a fixed sort of plate under the big toe, so that it doesn't move anymore. And the less the movement, the less the pain.
Okay, cool. Have we got anything left? Turf toe.
I'd like you to talk about the turf toe, please.
Turf toe. Okay, it's essentially a sprain. It's essentially a sprain of the plantar capsule. So it's the first MTPJ structures. That includes the plantar plate, includes the collateral ligaments, includes a lot of the structures within there. Happens a lot to athletes. So during the push-off stage, so you're going to send your joint into hyperextension, and it can be managed very effectively by just reducing the swelling, and you may need orthotics. I see this quite a bit because I see athletes, so I've seen footballers with this. I'm recently been treating a couple of like decathletes, and one of them had turf toe, and they would present with just horrible pain and stiffness around the big toe. I've never had to send anybody off for surgery ever. It can be managed quite, but I sometimes have changed. It's really hard with certain athletes, because with athletes, they're very particular about what goes in their shoe, because it's all about performance more than anything else. So it's been an interesting conversation when I've had to give them orthotics. So I've had to change them a few times, and I don't really mind as long as the patient is happy with it. But you can, if you get your foot in that position at any stage in a sport that you play, or if sometimes in a rugby player, if they're in a ruck and they get pushed, their toe will be forcibly pushed into that position. It can also cause that kind of damage. So we've moved. When I first qualified, we would talk about price, which was protection.
Protection, rest, ice, compression, elevation.
Yeah, and then we moved on to like police, didn't we? So police was protection, offloading, and all the rest of it. Now, you know what we've gone into now? Peace and love.
Peace and love.
Peace and love, bro. It's completely changed. They've given us a new acronym, and I'm going to go through it at like a different time. But now we're talking about, one of the things is when you have a sprain, you're not supposed to give anti-inflammatories. You're not supposed to put ice on it because they want inflammation to occur so that the healing process kickstart in. But if you ever watch a Premiership football game and you see a footballer they always put an ice pack on it. And these people are the best doctors in the world. So I don't know about this.
Just like me, they probably haven't heard about peace and love.
They have, trust me. But yeah, it's just managed as like a sprain, and it's not a chronic thing generally. Unless a patient's constantly getting it, then we'll have to start taking some X-rays and an MRI to find out what's going on. What about you?
I don't know whether you've come across this or not, but you can actually get some carbon fiber insole plates, and I quite like them.
Nick Knight introduced me to them. Yeah.
They generally they don't take a lot of space in the shoe, and they can provide that stiffness even in the shoes which are really tight or which are really doesn't have a lot of space.
I gave them to one of my 400-meter sprinters once.
They must be bouncing around.
But anyway, but yeah, I think that covers turf toe really, unless there's anything else you want to add.
No.
Sesamoiditis. Okay, so see, what are sesamoids?
Well, sesamoids are little bones which are present in the tendon which attach to a bone. So sesamoids, we've got sesamoids all over the place in our body, but the ones which we are talking about are right underneath the toe.
The two
right underneath the toe.
That place inside a tendon. So we normally diagnose this by palpating. So when we palpate it along, one of the things that can happen, we've mentioned ditus, meaning there's inflammation. You can get bifurcate. You can actually get it breaking off as well. You can get fractures and stuff like that. You've mentioned everything, and it covers it. Look, padding, strapping, taping, immobilization, non-steroidal anti-inflammatory, steroid injection, orthotics, surgeries. Never ever take the sesamoids out.
You say that, but I had a few months ago, I had a patient, a young lady who has been suffering with sesamoiditis, hypermobile, a lot of movement in her joints, had all the things apart from the surgery. She had guided injection from the dorsal aspect. She had guided injection from the Royal Orthopedic from underneath, like all these top consultants doing all these things for her. But she was still in severe pain, and I was the one who referred her to surgery.
Okay, how is she getting on now?
Well, I haven't heard anything just yet. So
I am of the opinion that those are like pivot points. I think they're essential. Those two little bones. If you take it out, I think force. We know from physics, force doesn't go away. forces it to transfer somewhere else, okay? And somewhere else that may lead to something a bit more substantial. I'll be interested to see how that lady gets on. I am not of the opinion that surgery for sesamoid discomfort or pain should ever be done. But I am not a surgeon.
Well,
So.
like I said, she had anything and everything done, and without any success.
I'll be interested to see what kind of outcome she gets. Let's see what kind of outcomes. Let's see if her symptoms have alleviated or have they increased, or if she's now got a secondary issue because of that. But that'll be interesting. This is really diagnosed by palpation, isn't it? I mean,
usually I think you can have X-rays and stuff later on, but usually 9 out of 10 times you can really diagnose it with palpation. Often you know that if there is a deviation of the big toe joint because of bunion and stuff like that, you can see that it's not fitting into the groove that it needs to fit into. I've got an image there which basically shows sesamoids and where they fit in. And as soon as they're move off their place, then they can come into we have a little ridge underneath the MTPJ, haven't we? And as soon as they come underneath a ridge, that's when they start to become symptomatic.
Cool. Yes.
Well, you wanted to talk about Joplin's neuroma. Go for it.
Joplin's neuroma, very rare, but it is a traumatic neuritis. So it often occurs right on the side of the big toe. It's inflammation of a nerve, very much like a mortise neuroma, which is what we're going to talk about in the next episode, but is usually caused because of a trauma that has occurred to the big toe, often misdiagnosed as a bunion pain, settles very quickly with very small amount of injection, sometimes conservatively just leave it alone for like a little while, just giving some anti-inflammatories. But it is something that I've only, it's like one of those things that if you only have a hammer in your toolbox, everything looks like a nail, okay? So I've only really started to pick these up in the last couple of years because I learned about them. Before that, I would have thought there's just random bunion pain. So it's like one of those things that once you know that such a rare condition can occur, and when you go through the history, you realize a traumatic, they banged it, something happened. And now they've had pain for 2 or 3, they've had pain for like 6 to 8 weeks and they can't understand because there's no bruise there. But they're getting these pins and needles, they're getting these shooting, they're getting all the neural symptoms that you would suggest. And you look at it and you think, what's going on here? And a couple of years ago, I wouldn't have known. But now that I know, I have seen it a few more times. But yeah, Joplin's neuroma, something that can happen.
Right. I think that takes us to the end of the presentation, and I'd like you to read this for me because I've got a picture in front of the court and I can't see the full court. So
okay, let me read it out. Tosif, this is for you. All right.
Well, Colombo.
Okay, sorry, Colombo. Keep your eyes on the stars and your feet on the ground. Theodore Roosevelt. Have you met him recently? Has he come to Harborne recently?
No, I love my quotes, so I thought I'll just add this right to the end.
Well, I hope all the viewers and listeners found this episode helpful. Our next episode is going to be on mortise neuroma, and we're going to carry on doing this until we are let loose out of the lockdown.
Absolutely.
Is there anything else you want to add, Tosif?
Well, I've enjoyed the first episode as well as this one, and I think since that I've started watching Colombo again. being at home, I've started watching Colombo And one more question, and I think he's fantastic.
So I have to buy a blue coat, and you've got to buy like a cream coat now, because that's what they wear, don't they?
I did start to take some pictures with the binoculars and stuff like that, magnifying glass, but I think that's a very good idea. I'm going to invest in one of these coats, and we ought to actually dress up and then sit down.
Yeah.
Well, you're going to be I won't have to do too much, because all I'll have to do is just look like a tramp, and I'll be Columbo. But you'll have to dress up.
I listen, I don't mind dressing up. It's one thing I enjoy doing is taking care of myself. So that's all good. Yes, I'm going to stop recording. I will speak to you soon.
Great.